Next up, we're fortunate to be joined by a well-known and respected and leading authority in the space of medicinal cannabis here in Australia. This wonderful woman leads the intellectual property, health and life sciences team at Mills Oakley, Sydney. She is both a lawyer and PhD qualified scientist. Ladies and gentlemen, please welcome Dr. Teresa Nicoletti, who will provide an overview of the regulatory and prescribing pathways in Australia. Welcome.
I've been thinking too much. I've been thinking too much. I'm boring, so I'm taking my time on my ride. I'm boring, so I'm taking my time.
Thanks, Helen, and I'd just like to congratulate Linda on her talk. What struck me from her presentation is it's like history repeating itself. We're about 10 to 15 years behind Canada in our regulatory framework, but we can see history repeating itself with some of the common themes that you'll probably hear a lot about over the next 2 or 3 days. And the issues are generally around affordability and access, also around the levels of education, particularly with which product to prescribe. And it's quite a sobering talk because we don't seem to have learned a lot from the international regime. We seem to be doing the same thing. So we've just got to work out what is it that we need to do to give patients affordable access to the right product. And let's have a discussion about that through the conference. Now, I don't seem to have a clicker. So I'm going to try and cover these topics today with some focus on nurses. This is a quick download. To do this justice, I'd need a full day with you, but you'd probably sleep for a week after that because it's content heavy. But let's see how we go. Thank you. So what I'll start with very quickly is how medicinal cannabis is regulated in Australia. So firstly, what is medicinal cannabis? Sorry, I have to keep looking over my shoulder to make sure I've got the right slide up. From a legal perspective, it's defined as cannabis that's cultivated, produced and manufactured into a finished dosage form for medicinal or therapeutic use. In legal terms, we use the term therapeutic use, but it's interchangeable with medicinal use. The common dosage forms that are used for medicinal purposes are inhalation, oral, sublingual, buccal, transdermal, topical, or suppositories and pessaries. We tend to talk about it as taking the two main psychoactive components, tetrahydrocannabinol and cannabidiol. But what we need to appreciate is that there are more than 400 compounds present in cannabis, including more than 100 cannabinoids, terpenoids, flavonoids, steroids, and other chemical compounds. So one thing we need to really understand here is that not all cannabis products are the same. They're very, very different. And the common concern that we have is identifying what product is best suited for each particular indication. And that requires a lot of research and understanding of the cannabis plant and its composition. So the basic legislative framework, and I'm really doing a very high-level summary of this, is that all domestic cultivation, production and manufacture in Australia is regulated under the Narcotic Drugs Act primarily and the narcotic drug regulations. There's other subordinate legislation that's relevant as well. The manufacture of the finished dosage form is actually regulated under the Therapeutic Goods Act. So we need to differentiate between what's regulated under the Narcotic Drugs Act and what's regulated under the Therapeutic Goods Act. If you manufacture an ingredient called cannabis, that's under the Narcotic Drugs Act. If you then take that cannabis and turn it into a finished product, that's regulated under the Therapeutic Goods Act. That's the main distinction between the two. overseas products, they're already manufactured, so they're not subject to the Narcotic Drugs Act, but they are subject to the Therapeutic Goods Act in how they are imported into this country and the standards they are required to meet. In addition to that, because they're controlled drugs, they're subject to the Customs Act and the Customs Prohibited Import regulations. So the person in Australia that imports the products into Australia must have an import licence and an import permit to import that shipment into Australia. The basic test for whether they get that import licence and permit is a fit and proper person test. National police checks, quite deep probity checks into whether you are fit to bring in imported medicinal cannabis. So the other thing you need to know is that all medicinal cannabis products are also regulated under state or territory legislation. Each state or territory has at least 6 primary acts and then a whole lot of subordinate legislation as well. So if you times that by 7 states, we're dealing with a lot of legislation every day. And I can tell you, I have a team of 5 lawyers that deals with medicinal cannabis every day. This is not for the faint-hearted. The danger in not getting the right advice is that you'll do something that's against the law and be subject to sanction. So we've been in this space since 2014, and the knowledge base has been built from dealing with this legislation every day. So medicinal cannabis are therapeutic goods. And what is a therapeutic good? Well, that's defined in the Therapeutic Goods Act in Section 3, and a therapeutic good is basically something that is for therapeutic use. We define therapeutic use in Section 3 of the Act as well, and the definition is up there. So generally it's anything for preventing, diagnosing, curing or alleviating a disease or condition, and it's generally something that acts by pharmacological, immunological or metabolic means. It is an offence in Australia to import, export, manufacture or supply any therapeutic good that is not entered in the Australian Register of Therapeutic Goods. So all medicinal cannabis products would ordinarily need to be registered in the Australian Register of Therapeutic Goods before they can be supplied. But the big underlying caveat is unless they are exempt goods, and I'll talk to you a little bit about that. And currently, the vast majority of medicinal cannabis products in Australia are unapproved therapeutic goods, i.e. they're not registered in the ARTG. The only 2 products that are registered are Sativex and Epidiolex. We had a role in getting Sativex on the market in 2012. It is a drug that's approved for multiple sclerosis, and Epidiolex was more recently approved for Dravet syndrome. So those 2 drugs, although they're registered, they're for quite restricted indications, and any other use of those drugs beyond that indication is called off-label use. But before I talk about exempt goods, I want to then take you to the poison standard, because that's another quagmire. Cannabis is listed in a number of schedules in the poison standard. So the poison standard governs how we regulate substances in Australia that bear some level of risk. And the classification system goes from Schedule 2 for the lowest risk medicines right up to Schedule 10, which are absolutely prohibited substances. We have CBD in Schedule 3 first, and the substance to be defined as Schedule 3 has a number of conditions which you'll see on the screen behind me. The main limitation for being able to use CBD in Schedule 3 is that the product must be registered in the Australian Register of Therapeutic Goods. Now remember, Schedule 3 medicines allow a pharmacist to be able to supply the medicine without a prescription, but it must be registered in the ARTG. There are a number of other limitations. You can only have a maximum of 150 milligrams per day dose in the prescribing. You have limited forms of administration, oral, buccal, or sublingual. And you can see the rest of the conditions there. Restricted to adults, it has to be in child-resistant packaging. And so it's not of much utility under the current scheme. And the other thing I will say is that to get a product registered in the Australian Register of Therapeutic Goods is quite onerous. When you're looking at a Schedule 3 medicine, you are required to conduct randomised, double-blind, placebo-controlled or active comparator trials in a representative group that would use the product in clinical practice. Now, they're not cheap. Robust clinical trials will cost upwards of $1 million plus. And so the regulatory burden to actually get a product registered in the ARTG is quite high. And for that reason, we're not going to see a product in the ARTG for quite some time. We're working with some clients who are working towards registration, but it's not going to happen, in my view, for at least the next 12 to 18 months. That would be the earliest time frame. CBD in Schedule 4. Now, that doesn't have to be registered in the ARTG, but again, you can see the conditions up on the screen. The main proviso here is that the CBD must be present in at least greater than 98% pure, 98 or more pure, and the other 2% can make up the cannabinoids, but they must be naturally derived cannabinoids. The carve-outs to the Schedule 4 listing recognise that there's also a Schedule 3 listing for CBD, and then there's also a carve-out for hemp seed oil, which may contain residual concentrations of CBD. Sorry. The vast majority of medicinal cannabis products are in Schedule 8. And I've underlined the wording, it has to be for human therapeutic use. So if you don't fit into Schedule 3 cannabis or CBD or Schedule 4 CBD and your cannabis is for human therapeutic use, you come into Schedule 8. And Schedule 8 is termed a controlled drug. It's in the same class as all the opioids, morphine, oxycodone, hydromorphone, buprenorphine. So they're regulated in the same way at a state level. And so there's some restrictions also on it being in Schedule 8. They have to comply with the requirements of the Narcotic Drugs Act and the Therapeutic Goods Act. So for a domestic product, they have to comply with both Narcotic Drugs Act and Therapeutic Goods Act, but if they're imported, they have to comply with the Therapeutic Goods Act. Tetrahydrocannabinol has its own entry. Before the poison standard was reworked to include cannabis in Schedule 8 and CBD in Schedule 4 and Schedule 3, there were just two separate entries for tetrahydrocannabinol and cannabis, but cannabis was in Schedule 9 at the time, but they retained the tetrahydrocannabinol in Schedule 8 because many, many years ago, a product called dronabinol was registered in Australia. And so the entry for tetrahydrocannabinol existed for that reason. So many, many years ago, before legalisation, you had tetrahydrocannabinols alone in Schedule 8 and then all other cannabis in Schedule 9. Now you've got the tetrahydrocannabinols entry in Schedule 8 still, but a new entry in Schedule 8 for cannabis for therapeutic use. And in 2012, when Sativex was registered, Sativex's active ingredient is nabiximols. Nabiximols is predominantly a one-to-one mixture of THC and CBD, and there are a number of other minor cannabinoids. And when that was registered in the ARTG, an entry was placed in the poison standard specifically for that active substance. So that's why that's in there. So, at the moment, if you're not using cannabis for human therapeutic use, it's a Schedule 9 substance, which means it's a prohibited substance. It can be used for scientific and analytical research, subject to approvals and authorisations in your state to do that research. But some of you may be aware that there has been a scheduling submission submitted to try and get the Schedule 8 entry changed to allow cannabis to be used for animal use. So we have this situation at the moment where you can use cannabis for human therapeutic use for Schedule 8, but you are prohibited from using it for animal use. So that's the next stage of the developing framework for animal use. And other than that, cannabis is a prohibited substance. So just briefly on the GMP requirements, all domestically manufactured product is required to comply with Section 36 of the Therapeutic Goods Act. That essentially means that you must have a GMP licence in order to be able to manufacture and supply medicinal cannabis products in Australia. For a long time there has been a lot of criticism around the unlevel playing field between domestically manufactured product and imported product, because imported product was not required to meet the same GMP standards. That has been rectified to some extent with a lot of lobbying by a lot of people in this industry, and it's had an effect. And to the audience here, I commend you to become part of the lobbying if you want to effect change, because Lucy and I are tired of it. We want to rest our laurels, but the whole reason we have had reform and change is because the industry has approached this with one voice, and we just need that to continue if we're going to address some of the issues that Linda raised in her presentation. So the overseas requirements are now that they need to meet a GMP standard, but the GMP standard is only the standard that applies in their country of origin. Now that's fine if the product comes from Europe or the US or Canada, because they have precisely the same regulatory standards that we have here. But if it comes from a less known country, and I'm not going to name the less known countries because then I sound like I'm discriminating, but there are countries that have standards that are much lower than Australia's, and those are not required to meet the same standards. Now, what are we talking about here? We're talking about quality and how important quality is as a measure of safety. And so if you don't know where your product is coming from, you should ask the doctor or the sponsor where the product has been sourced from. As far as I'm concerned, Australian domestic manufactured product is gold standard. And we're assured of that quality because we've got the most rigid system for regulation of medicinal cannabis products in the world. And it's quite a restrictive scheme which could be relaxed a little bit more, and there could be more resources allocated to getting domestic manufacture up and running here. But for the most part, we have world-class products coming out of Australia. Both overseas and domestic products are required to comply with Therapeutic Goods Order 93, and that sets out the minimum standards for quality of incoming product anyway. So at least you know that companies that are exporting products to Australia are required to test their products and certify compliance with TGO 93. And it is the sponsor's obligation who is importing the product into Australia to ensure that that product complies. Now, there's been a recent change to extemporaneously compound medicinal cannabis products. Extemporaneously compounded products are those products that are manufactured by a pharmacist. So there's a neat little exemption in the Therapeutic Goods Act that actually says that medicines that are extemporaneously compounded or dispensed for a particular person for therapeutic application to that person are exempt from the requirements of Part 3.3 of the Therapeutic Goods Act. Now you can see that I've been working with the Therapeutic Goods Act for so long that I can pretty much recite these provisions constantly. But there was a concern around quality of compounding by pharmacists because they're not beholden to GMP standards. So how do you know if the pharmacist is going to manufacture a product that's of acceptable quality so that it's of acceptable safety for the patient? TGA decided that before they will allow that compounding, a pharmacist now has to go and get an SAS, sorry, the doctor has to submit an SAS application and get TGA approval to be able to compound. And I'll talk about that scheme right now. So, access pathways. The medicinal cannabis products that are supplied in Australia are called exempt goods, and exempt goods are able to be supplied under three main pathways: authorised prescriber scheme, special access scheme, and clinical trials. And I'll mainly talk about special access scheme because it's the most predominantly used scheme. Sorry, I forgot to forward my slides. So there's three schemes under the special access scheme: Category A scheme, Category B scheme, and Category C scheme. The Category A scheme is a scheme that allows a medical practitioner to prescribe a product without seeking any prior approval from the TGA. It's called a notification scheme. The prescriber can write a prescription and dispense a prescription under that scheme to a patient who has a life-threatening condition, is seriously ill, and from which death is reasonably likely to occur in the absence of treatment. It's not a very widely used scheme because you need to meet those criteria. The advantage of it is that it fast-tracks the ability to prescribe to a patient. What the prescriber is required to do is within 28 days submit a notification form to the TGA to say that they have supplied a product under Category A. So Category B is the predominant scheme, which is for every other use, and that requires an application to be submitted to the TGA for approval. It's an online portal. Many years ago when we started this process, the SASB approvals were taking several months. You now can get turnaround, sometimes even the same day, to 24 to 48 hours. So it's a well-oiled machine now after several years of running. There's also Cat C. Cat C drugs are those that have had a long established history of use for particular indications. There's a list of drugs under the regulations that are approved for Cat C prescribing. Medicinal cannabis is not one of them. Sorry, I did it again. It's because I've got my back to the screen. So that's the three screens. You'll have all this in your notes, so whatever I'm talking about, it's all covered in the notes. I commend you to go to the TGA's website. The link is on the bottom of this page. They've got some really interesting data around the uses of medicinal cannabis, and it's also a wealth of information about medicinal cannabis if you ever want to go to that website and learn more. But this shows you the number of approvals of SASB applications since legalisation. And legalisation was in November 2016, so you can see there's no approvals in 2016. And then you start to see them creep up. What you need to appreciate is that a lot of work went into improving these numbers, because when we started out, there was not only a federal layer of regulation, but there was a state layer of regulation, and it was a stifling barrier to approval and access. Lucy and I went on the warpath a few times, including an entourage to Canberra, to lobby for the state scheme to be removed, and that happened in 2018. And look what happened to the numbers since then. And it's quite significant numbers now. In 2021, you're looking at, there was about 130,000 SASB approvals. This year we're tracking to exceed that, looking more, pushing up to 200,000. So that tells us that access doesn't seem to be an issue now. What is an issue is, though, affordability and the prescribing of the right product. And that's the theme of Linda's discussion, and it will probably be a theme of the conference. If if you look at the indication, the vast majority of SASB approvals are for chronic pain. A huge number. Now, what does that tell you? That tells you that there's an unmet clinical need for chronic pain. And so our opioids, which have been the mainstay of treatments for chronic, moderate to severe pain, are not working. The benzodiazepines are not working. Other drugs are not working. And patients have been resorting to other products to treat their symptoms. Now compare that to the Category A notifications. These are the numbers. Now look at the graph on the bottom. This is actually 500 as opposed to the access on the Cat B slide. So there's only been just under 600 SASA approvals in 2021, so we'll probably see around the same for 2022. So to get, in the indications there, you can see again chronic pain. The predominant use for SASA is chronic pain related to cancer, chemotherapy-induced nausea and vomiting. They're the predominant uses. I'm rushing because I know I've only got 5 minutes. I'm going to actually, in the interest of time, what I'm going to do is to go straight to nurses, can we prescribe medicinal cannabis? So some nurses can prescribe medicinal cannabis, and that those that can prescribe must submit an application for SASB approval, or the doctor can submit an application for SASB approval and actually then allow the nurse to administer the product. I recommend in all circumstances the latter. There is not a lot of appetite at the moment for nurses administering medicinal cannabis. It's all this stigma around its use at the moment. And it's also getting a lot of regulatory attention, negative regulatory attention. AHPRA, HCCC don't like nurses administering medicinal cannabis at the moment. So just be aware of that from a risk point of view. Nurses and nurse practitioners are subject to state or territory laws around possession and supply. And again, remember, each state and territory is extremely different. And I've given you 2 examples there. In Victoria, nurse practitioners can prescribe medicinal cannabis that's S4 in the course of their profession, but if it's an S8 medicinal cannabis product, they require a special permit. In New South Wales, nurses can prescribe medicinal cannabis in the course of their profession as long as they have an endorsement under Section 94 of the national law, or otherwise an authorisation under the state legislation. Now, I've done a table here that shows you, one of my junior lawyers had the wonderful task of going through all the legislation and just having a look at where the permissions are, but read the red thing at the bottom. It doesn't automatically mean you can do it. It is subject to other authorisations or approval, so you must obtain the right endorsement or approval in your state or territory before you do anything. And I don't think a lot of nurse practitioners know that. So please be careful because there are significant risks. Oh, there it is. Disappeared. Look at it. Potential liabilities. So this is my last slide. You need to be mindful that medicinal cannabis products that contain THC or other psychoactive cannabinoids do have a potential for misuse and abuse, and all medicinal products have risks. There's no such thing as a product having no side effects. So I don't want to hear that coming out of any practitioner's mouth. There are potential dependency issues, there are potential interactions, and you need to be very careful when you prescribe any controlled drug. I can't say that strongly enough. We've dealt with quite a few complaints about prescribing that has been done inappropriately. There's a potential for impairment with THC containing drugs, And at the moment we have an inconsistency in law through the drug driving laws that make it a strict liability offence if there is any THC present in your system while you are driving. We are dealing with those laws as much as we can. In fact, there's a bill before the New South Wales Parliament which we submitted to the Senate inquiry on, and hopefully the law, at least in New South Wales, will be changed. In Tasmania, it's not an issue, but in other states it is. So please make sure of the law in your states or territories and make sure you advise the patients accordingly. In terms of mitigating your risk, you're using an unapproved product here, and unapproved products do not have established quality, safety and efficacy. So wherever possible, you need to obtain genuine informed consent from your patient. What's genuine informed consent? It's not just, I know I'm taking an unapproved product. You need to identify what the potential risks are, and the person needs to fully understand what they're taking and the potential safety risks. If you're giving them a very high dose medicinal cannabis product, particularly high dose THC, consider also a patient indemnity form. So in some circumstances where patients are end of life and need high doses to give them some quality of life before they die, you don't want to be in a situation where that patient suddenly just dies from an excessive dose, even if that may be very unlikely. So you might want to consider a patient indemnity at that time. The main issues we see are around whether insurers will cover you for use of an unapproved product, so check with your insurer. Many doctors are still reluctant to prescribe medicinal cannabis, so it's finding the right doctor who will want to prescribe the product, and then a doctor who knows what the right product is. And as I said before, in the current climate, if you are a nurse and you are administering medicinal cannabis, you may attract negative regulatory attention. The primary issue is around quality, safety and efficacy, and whether it's been tested. So that's it. I just want to show the screen of the Cannabis Warriors at Mills Oakley. They're the people that allow me to stand up here and talk to you today, and I could not do this without them. Thank you all.
Thank you so much, Teresa. Ladies and gentlemen, please congratulate Teresa on that incredibly informative presentation. We could listen to you all day, and I don't know if many of you, I saw a few of you, but I was definitely taking copious notes. Just when you think you know what's going on, then we're presented with another interesting fact. So thank you very, very much, and we look forward to seeing more of Teresa in the symposium over the weekend. Pretty sure that you're hosting about 1,000 panels, so, you know, look forward to seeing you. So, excellent.